It looks like we have another full house today in the audience with around 100 or so registrations from across the globe. So welcome one and all. Now, our keynote speaker will present a 40-minute talk, which will be followed by 15 minutes of Q&A, and we'll close the webinar exactly on the hour. If you'd like to ask a question, please type your question into the chat at any time during the webinar. And at the end of the 40-minute talk, the moderators will ask the speaker your question. At the end of the talk, please click on the link that we'll put in the chat to provide a brief 2-minute feedback, which helps us curate the SCONA webinar content. If you'd be interested in presenting a talk yourself, please do contact us. Now, the moderators for today are both myself and my good friend and colleague, Kiao Inthavong. My name is Narinder Singh. I'm the Chief of Otolaryngology at Westmead Hospital in Sydney and an academic at the University of Sydney with a research focus on CFD and artificial intelligence. My colleague and fellow moderator, Kiao, is an engineer and an associate professor at RMIT University in Melbourne, who specialises in CFD of the respiratory tract. And a special thanks to one of Kiao's many PhD students, Brenda, who is the convener for today's webinar. So I'll now hand over to Kiao, who has the very great honour of introducing our keynote speaker for today's webinar. Thanks, Kiao.
Thanks, Narinder, for that introduction. And it's my pleasure here today to introduce Dr. Oveis, who's a research fellow at the University of Adelaide. He leads the ENT Biomech Research Node. His work focuses on aeroacoustics, CFD, respiratory biomechanics, and medical device innovations. He's published over 40 peer-reviewed papers and secured more than $2 million in competitive funding. Dr. Oveis also teaches and supervises students bridging engineering and clinical practice to advance healthcare outcomes. Dr. Oveis also joined us in Brisbane for the SCONA 2023 Asia-Oceania meeting, and we hope to see him again, as well as the audience here, in our future meetings. So it's with great pleasure that I introduce Oveis for his wonderful presentation tonight. Over to you, Oveis.
Thank you, Kiao and Narinder, for the introduction. Now I want to share my screen. So, first of all, I would like to thanks to the Narinder and Kiao for making the SCONA, and I think it is really good. And today I would like to talk about innovations in sinonasal drug delivery, and I would like to start with the content, and I start with the content of the webinar tonight, and I will cover first how we go from CT scan images to 3D printed sinus models. Then I'll compare the bottle wash and nebulizer using in vitro test. Then we will look at micro CT scan, see how micro CT scan can help us to visualize drug delivery and the position pattern. And finally, I will explore how acoustic waves can support drug delivery into paranasal sinuses. Before go to the mechanical engineering part, I would like to give you an introduction to the paranasal sinuses and the disease that we aim to treat. The human body has 4 types of sinuses in each side of the nasal cavity, including frontal, maxillary, sphenoidal, and ethmoidal sinuses. When these sinuses stay inflamed or infected for more than 12 weeks, it's called chronic rhinosinusitis or CRS. In the image here, the left side shows a healthy sinonasal cavity, while the right side is the infected cavity of the sinus and nasal cavity, and the yellow areas indicate the infection actually. CRS affects about 10% of the global population and can lead to persistent discomfort, pain, nasal discharge, and lower quality of life of the patients. And the treatment typically includes both systemic and topical drug delivery, whether the surgery is involved or not. But in this webinar, we will look at topical drug delivery to sinuses from the lens of fluid mechanics and computational fluid dynamics. Common nasal drug delivery methods include nasal irrigation, using bottle wash or neti pots, nebulizers, and nasal sprays. In today's talk, I will focus on nasal irrigation and nebulization. To analyze drug delivery, first of all, we should actually make a 3D model of the sinonasal cavity. Indeed, we first need to find a reliable method to measure how much medication reaches each sinuses. One effective, low-cost, and accurate alternative to cadaver studies is using a 3D printed model of the sinus nasal cavity. This starts with reconstruction of CT scan images into a 3D model, as shown here. Here you can see one slice of a 3D model from different views, and the colorful areas shows the reconstructed model of the nasal cavity, including sinuses and the actual nasal cavity. So we actually use the open source software 3D slicer for this purpose. After creating the 3D model from 3D slicer, we export it as an STL file. Then we use a space claim or mesh mixer to clean the geometry to remove any sharp edge and any artifacts. Next, we create a shell with the right thickness. And this step is actually it is the most important step in 3D printing of the nasal cavity to be low cost and accurate. We tested different resins and thicknesses of the model, and we found that 0.75 millimeter works best for the healthy or post-operative, pre-operative models. And for the post-operative model, when we have ethmoidal sinus removed, a 1 millimeter of the thickness is reliable. We actually use clear or white resins, which are very low cost. And for doing this method, we use a 3D printer that is an SLA 3D printer, which has an adaptive mode to have adaptive resolution from 20 micron upward. To measure the medication deposition inside the sinuses in the lab using the 3D printed model, we actually need to cut the 3D printed model in several parts to be able to access inside the sinuses. So we usually separate the frontal, maxillary, and sphenoidal sinuses as shown here. Then we add phalanges to cut the sections so we can easily reattach the parts in the correct orientation for conducting the drug delivery experiments. We actually use two methods to attach the parts. To attach the two parts of the sinuses to the nasal cavity, we can use either zip ties, a simple zip ties, or a magnet. With the zip tie, it's really secure, but it's really time consuming since we have to cut and replace them for each test. So it's more suitable for permanent setups like micro CT scans, which I will discuss it later. The second one that I said is the disc magnets. It's really quick, easy to detach, and ideal for repeated in vitro tests. This method really speeds things up. And as you can see here, this video shows how easy it is to assemble the parts together to do the drug delivery test. So it's really speed up the process, and it can be better, quicker, and more accurate than the cadaver. After performing the in vitro test, for the drug delivery simulation, we actually need to wash out the sinus walls to collect the deposited medications or any drug tracer. The challenge here is that when we try to wash a sinus that's connected to the nasal cavity, I mean, this part of the sinuses, like this is the maxillary sinus, the wash liquid can actually leak back into the nasal cavity, which affects the results, and it reduces the reliability of the test. To solve this problem, we designed 3D printed a custom, actually, a pin made of the silicone that fits perfectly into the ostium, as you can see here. By sealing this ostium with this 3D printed pin, we can wash the sinus without any backflow into the nasal cavity, which makes the process much more reliable. So this is a very, very good example of how 3D printing can enhance the accuracy and the realism of the in vitro test for simulation of drug delivery to paranasal sinuses. Based on the steps I discussed, we have 3D printed two models. We have, of course, we have printed several models, but now I'm going to talk about the two of them, including one normal sinus without any surgery and without any disease, and one post-operative sinus with for a patient. We tested bottle wash using both hand squeeze and a pump, and also tested a nebulizer. For the bottle wash, we diluted a 5 milliliter of 2.5% sodium fluoride into 120 milliliter of water. And for the nebulizer, we used 5 milliliter of undiluted NaF with a droplet size of 12 microns. And the reason for dilution is that if you want to use an expensive medication like phage, we cannot use bottle wash for that one, because, for example, for 240 milliliter use for one single dose, so it is really expensive. But with the nebulizer, we can actually keep it as it is without any dilution, because the nebulizer can nebulize 5 milliliter of that medication. Actually, for the head angle, actually, using the bottle wash drug delivery, we used a 24 degrees compared to the horizontal plane, and the pump delivered at 30 milliliter per second. Most in vitro studies in the literature that studies on nasal irrigation focus only on the drug deposition right after the delivery. But in the real life, patients blow their nose and especially move their head to avoid drips after the nasal irrigation using bottle wash, which can either flush the drug out or push the drug into the sinuses. This step is often ignored and can lead to over or underestimating the drug delivery. To assess this, we actually measured the fluoride level in the sinus before and after the head movement using an ion-selective electrode meter. I should say that we use fluoride because the sodium fluoride includes the fluoride ion, which is really detectable with high accuracy of 0.001 ppm, and it is very easy to clean the surface using distilled water. So we can collect all of the fluoride from the 3D printed surface. So the results, the left figure is for the normal sinus. The normal sinus showed no major changes, likely due to the small ostium it has. Also, you can see the red is higher than the blue, but statistically they are not significant change between them because of the high variability between the tests. But in post-operative models, head movement significantly reduced the deposition efficiency in the maxillary sinus. But as you can see in the right figure for the nebulizer, the performance of the nebulizer remained unchanged by head movement. So what we can conclude is that the head movement, which is really important in measuring the drug delivery efficiency for bottle wash, should be actually considered in our studies. And nebulizer showed very consistent results for drug delivery. This image helps explain the results we just saw in the previous slide. After nebulization, the droplets are evenly distributed along the sinus wall, as you can see. I hope you can see the droplets here, because of the scattering of the light, it might be not very visible. The droplets of the liquid, the solution of the NAF, are here distributed evenly. Because they stick to the surface, head movement doesn't really displace them because the gravity is the only force acting on them, and they are very small droplets. But with the bottle wash, actually, as if I can open the videos, sorry. Yeah. Yeah, if you can see, with the bottle wash, a larger volume of liquid can collect in the sinuses, and when the head moves, that liquid can flow back into the nasal cavity. It reduces the actual drug delivery deposition. So this movement should be considered at high amount of the medication can flow back to the nasal cavity. Another issue with the bottle wash was for the bottle wash delivery is the inconsistency in how it's applied in real world. With bottle wash, the flow rate is inconsistent. It varies between users, even between uses. I mean, the use of the drug delivery at different times of the day. This really affects how much drug reaches the sinuses. This creates uncertainty in how efficiently the medication is delivered. We compared the hand squeeze bottle with the pump delivering that delivers steady flow. The pump performed better, as shown in the figure, in the left figure. We can see that the pump had higher drug delivery efficiency than hand squeeze bottle with head movement after the drug delivery. And the right figure shows that hand squeeze delivery had much higher variability, especially with hand movements. So in contrast, we can see that the nebulizer provided consistent drug delivery across all the tests. Let's jump to the next part of the talk. Here I'll introduce a method that allows us to accurately measure and visualize particle deposition in sinuses using micro-CT scan imaging technology. One challenge here is that we perform the drug delivery simulation in the fume hood, but the model has to be moved to the micro-CT scanner. Any movement or shape during this transport can alter the actual deposition pattern. How to fix it? To prevent this, we actually let the model to dry out after the simulation of the drug delivery. It takes about 24 hours. Then we move it to the micro-CT scans. So with this method, we ensure that the distribution stays intact. But to visualize the deposition in the 3D in the 3D model using micro-CT scan, we need a visible marker. We first tried the iodine. The iodine is vastly used for the scanning of the human body, but it wasn't detected after drying, as you can see in the left picture. So we tried different solutions, and finally we found that lead citrate can work, and at the right concentration, it showed up clearly in the micro-CT even after drying. So we used lead citrate to nebulize 5 milliliters of lead citrate in 10 minutes using the nebulizer. And the left picture shows the deposition pattern of the lead citrate, nebulized lead citrate in sinonasal cavity. And the cavity was also 3D printed using the same method that I discussed, but in this time we use the zip tie, because if we use magnets, the magnet scattered the X-rays, so we couldn't get such nice results. And actually, we also ran a CFD simulation using the discrete phase method in the ANSYS Flu, and which showed a similar deposition pattern in the right image. However, since the delivery time was much shorter than the real life, fewer particles collisions occurred. And in real scenarios, more collisions can create larger droplets, as shown here as white regions in the images. So we couldn't capture them in the CFD. But if we look more closely, we examine the left maxillary sinus and compared the micro-CT results with the CFD prediction. Both show deposition on the sinus floor is higher than the other part. That is mainly due to the gravity. Overall, the CFD and micro-CT patterns match very well, but some tiny droplets appear in the CFD, but like this in this area. So if I show you the laser, yeah, in this area you can see droplets in the CFD, but not in the CT. This actually can be due to the resolution of the CT scan images. The micro CT resolution was 34 micron, so anything smaller couldn't be really detected. If you see the simulation, the CFD simulation, there are some particles here. Of course, it is after 5 seconds, but some particles, or single particles, are deposited here, and based on the contour here, you can see that most of the particles are less than 34 millimeter in diameter in this area. So most probably the CT scan images, the CT scan couldn't actually detect those particles. Using micro-CT can really help us to detect the deposition pattern of the nebulized particles in the paranasal sinuses, and based on this, we can actually improve the design of the medical devices, such as nasal sprays or maybe nebulizer. Also, we can use it for validation of the CFD model. This technique can also be used, I think, in drug delivery to human lungs, and because of the very small diameter of the lower lobes, so this can actually be used. Let's jump to the next part of the webinar, that is about acoustic drug delivery. Here, now I want to talk about an innovation drug delivery method using acoustic waves. Since 1950, acoustic airflow has been added to nebulizations to improve aerosol delivery into sinuses, mainly for treating CRS. This approach actually began when the researcher observed that workers operating electrical machines often had dust particles trapped in their sinuses. So these machines produce low frequencies at 50 hertz and 100 hertz. So this actually led to the idea of using sinusoidal sounds, especially at 50 hertz and 100 hertz, to support drug delivery penetration into the sinuses. Later on, this concept was questioned, and it was in many previous research. You can see that this is based on Helmholtz resonator principle. I mean, penetration of particles into the sinuses. The principle is this: a Helmholtz resonator is a cavity that it is a cavity that has a neck. When an acoustic wave externally is applied with a range of frequencies, the air plug inside the Helmholtz resonator neck starts oscillating, and the oscillation is maximized when the acoustic frequency of the outdoor environment is equal to the resonance frequency of Helmholtz resonator. But the Helmholtz resonator frequency can easily be measured using this formula and some other corrected formulations. But all of them are working for actually a spherical cavity and cylindrical neck. So if we consider the cavity of the Helmholtz resonator as a sinus, here as a maxillary sinus, and the neck of the Helmholtz resonator as the ostium in the nasal cavity, we can assume that by applying an acoustic wave to the nostril, we can excite the air plug inside the ostium to oscillate, and the oscillation can be at its maximum level. I mean, the amplitude can be maximized at the resonance frequency. Because this resonance frequency equation is very simple, and we try to figure out if it works in nasal cavity or not. To do so, and to better understand the sinus resonance, we began measuring it experimentally. We started using a simplified model. It includes a straight tube and two side cavities, and we use a maxillary sinus cavity with the same volume and shape for both sides, and connected them to the main duct using a straight tube with different diameter, and then started to measure the resonance frequency. To measure the resonance frequency, we used a microphone at the input and microphone at the response point, and measured the acoustic pressure by the time, and did the transfer function estimation, and found the peak value that is the resonance frequency. We also used a CFD simulation because using a CFD simulation, we can get more detailed data and information and to understand the underlying mechanism of acoustic drug delivery. We used the same geometry for the CFD modeling, and here we did a mesh independence test. I should say that for the experimental setup, we used white noise as the input, but here we used a sweep frequency for better convergence of the CFD modeling at 20 hertz to 2000 hertz at the amplitude of 3 Pascal. And the good thing here is that for the left and right right cavities, we could do the mesh independence test very well, and we can see that the medium size of the cell was independent of the was selected as a mesh independent size. So we use 6.64 million of cells for this modeling. Here we started doing validation study. With the validation study, we use actually transfer function. We use the transfer function versus in the frequency domain to see how well the CFD could actually measure the resonance frequency compared to the experimental setup. It is interesting that the results was good, and we had very good agreement between the experimental data and the CFD. You can see that the the solid lines show the CFD simulation results, and the dash lines show the experimental data. You can see that the resonance frequency obtained by CFD is 366 hertz, but it is 380 hertz for experimental data, and there is only about 4% of error between them. And another thing to validate the CFD modeling is that the trend of the transfer function in the frequency range between 60 hertz to 2000 hertz is really similar to each other, and it actually confirms the accuracy of the CFD model. So after doing this, and we measured the resonance frequency of each cavities based on the formulation we had in the previous slides the equation of the Helmholtz resonator. The theory showed the different resonance frequency for each sinuses. For example, for the left cavity, the theory actually calculates the resonance frequency at 489, which is about 100 hertz more than that of the experimental, and the right cavity has even 100 hertz more than the left cavity. So first of all, it showed that the theory doesn't actually account for the interaction between the sinus, between the cavities and the main ducts, and it calculates the resonance frequency very different to the experimental setup. So we cannot rely on that. But the CFD simulation worked well with calculation of the resonance frequency. And the other thing, an important thing, is that we can see that the blue and the red lines show the resonance frequency of the left and right cavity respectively, and both cavities showed one single resonance frequency, but in the theory we had different resonance frequency for each cavities. So the experimental setup is verified, and we can understand that this method of measurement that has already been done in previous studies is not correct for getting the highest energy from nostril into the sinuses, the acoustic energy. Then we try to expand our work to realistic model of sinonasal cavity. Now let's look at acoustic analysis of a normal sinusoidal normal sinonasal cavity. We 3D printed the model with the way, as I explained before, but with magnet holder for the attaching the parts. But this time we added 1/8-inch holes and some holders, and to place the microphones inside the sinuses. Due to the complex shape of the frontal and sphenoid sinuses, we tested multiple microphones position to see if geometry affects the resonance frequency. As you can see, the frontal sinus, we put 4 microphones, and for the sphenoid sinus, left sphenoid sinus, we put 2 microphones. And then the results showed interesting thing for us. This result is for frontal sinus, and in the left frontal sinus that we use 4 microphones, the transfer function plot shows no change in resonance frequency in the highest resonance frequency in this peak. And for the other 2 sinuses, the right frontal sinus and the left sphenoid sinus, it was the same, and we didn't see any changes in resonance frequency. So the shape of the sinus doesn't change the resonance frequency of that individual sinus, actually. When we compare the transfer function from all microphones, I mean, from the pressure response at all sinuses, all sinuses showed a strong, consistent resonance peak around 272 hertz. This suggests that there is a global acoustic mood that couples efficiently into all sinuses, regardless of their shape or location. Each sinus also had smaller unique peaks, like these peaks, and so this is likely from local resonance modes. If we use an acoustic wave at this mode, we can actually expect have a resonance frequency and a little bit higher amplitude at the ostium of this sinus. But these are very weaker than the global mood. So it means that less acoustic energy reached them. So the highest acoustic energy can be transferred to all of the sinuses uniformly if we use the global mood, not measuring the resonance frequency and applying the frequency input at the local frequency of each sinuses, except for the right sphenoid sinus. For the right sphenoid sinus, we have a very high peak here at 1240 hertz. That the magnitude of the transfer function is similar to that of the global acoustic mode. But to better understand if this mode is better than this mode is this frequency is better than this frequency for acoustic drug delivery to all sinuses, we should actually get better understanding of the flow dynamics in the paranasal sinuses of this normal and healthy sinus cavities. To do so, we actually did the CFD simulation of the same geometry that we did the experiment on that. In this simulation, we used the same mesh strategies as we use in our simplified model. And we applied an acoustic wave at the left nostril, traveled to the nasal cavity and all sinuses, and then exit from other nostrils. So I just want to confirm that we used a bidirectional drug delivery system here. And the result is interesting. To evaluate the CFD model, we actually compared its results with experimental data for the frontal, maxillary, and sphenoidal sinuses. The solid lines show CFD results, and dashed lines also show experimental data. But and the blue for the left sinuses and the red are for the right sinuses. The agreement between the CFD and experimental data was really strong, with CFD overestimating the resonance frequency by about 7.5%, which is acceptable given the complexity of such geometry, and there are some slight difference between the boundary conditions in the experimental and CFD modeling. The first row shows transfer functions, while the second row and the third row show the pressure fluctuation in each sinus. Black lines also represent the input pressure that is at the nostril. You can see that at the resonance frequency, at this frequency, the global resonance frequency, we actually the sinus pressure have the sinus pressure spikes significantly. Here and in these green areas, while the input pressure stays almost same. That is the black lines here. This shows that we can create a pressure gradient into the sinuses by applying right frequency, which is the global resonance frequency of the sinonasal cavity, without increasing the input pressure. And we know that the greater the pressure gradient, the more air exchange is likely to occur between the nasal cavity and the sinuses, so the drug delivery to the sinuses can be increased. In our CFD model, we divided the geometry into separate cell zones, one for the nasal cavity and one for each sinus. This setup allows us to track the air mass in each sinus individually. The top row show the mass fluctuation results, and the bottom row shows the results of the pressure fluctuation and the transfer function between the input and the response point in the sinuses. Because air is compressible, acoustic waves cause the mass of the air in each sinus to fluctuate, even though the sinus volume stays constant. This fluctuation indicates that the air exchange between the nasal cavity and each sinus, how the air fluctuation between the nasal cavity and sinus are. And what is interesting is that at 1,240 hertz, the sphenoidal sinus shows the highest pressure fluctuation, the light blue one here. But its mass fluctuation is much lower than the other sinuses. I mean, here, this is the mass fluctuations. So, also, the left frontal sinus has a higher transfer function than the left maxillary sinus, yet its mass fluctuation is lower. Here you can see it better. This is likely due to the sinus volume. This table shows the sinus volume in the actually in descending orders, and it matches the trend in the air mass fluctuation seen in the FFT. And this is the FFT of the mass fluctuation. This means that I want to say that by increasing the volume of the sinus, the FFT increases, which this FFT increase is not similar to the transfer function. Simply, we can say that even at the resonance frequency, smaller sinuses may show less air exchange despite higher pressure, simply because there is less space to move in and out in the sinuses. So the pressure gradient is not the only way to improve the drug delivery. We should also consider the size of the sinuses. To summarize, the 3D printing with disc magnets gave us a quick, low-cost, and accurate way to measure drug delivery. MicroCT helped us clearly visualize how particles deposit inside the sinuses. CFD was able to accurately predict resonance frequency even in complex sinus geometry, and also the low frequency excitation and the global resonance is the most effective strategy for delivering nebulized particles across all sinuses due to its strong and uniform pressure coupling. Finally, we found that the air exchange depends on both the sinus size and its resonance frequency. And a quick word about our group. We are a multidisciplinary team, research team made up of surgeons, medical scientists, and biomedical engineers. The ENT Biomed research node is a part of ENT surgery research group led by Professors Wormold, Professor Saltis, and Professor Rood. I also lead the ENT Biomech research node, which currently includes 5 PhD students with a portrait here and a research assistant. This work actually wouldn't be possible without the support of this fantastic team. So I would like to sincerely thank all of our group members and all of the collaborators around the world. I would also like to thank the University of Adelaide, the Patsy and Williams Foundation, the Basil Hetzel Institute for Translational Health Research, where our labs are located there, Medical Research Future Fund, and Phoenix High Performance Computing for all of their support, funding, and resources. Thank you for your attention, and I'm open up for all of your questions.
Well, ladies and gentlemen, I think we'll all agree that Oveis is to be congratulated for an outstanding talk and some really fascinating experimental results. So we do have time for discussion. So if you would like to ask a question, please type it in the chat, and the moderators will ask your question for you. And just while we're there, Brenda, if you could put the link for the feedback into the chat as well. And if I could ask the audience to just click on the link for the feedback, it'll only take around 2 minutes, and it really helps us curate the content of future webinars. So it looks like we do have a question from Jake, and Jake's mentioned for a great talk, that's which we all agree. And Oveis, the CT scans show quite qualitative results. How easy is it to quantify these data? Because we're more interested in deposition fraction values.
Yeah, thanks, Jake, for your nice question, and I think it's a very good point. It is actually really it's easy to measure quantitatively using, for example, using a software called CTAN. We can quantitatively measure all of the deposition, even the deposition of in each sinuses. But it is tedious and it is not easy to do so. It is time consuming, but it is doable, and accurately you can measure the volume of the lead citrate, and because we know the actually the density, we can measure the mass of that one and then compare it with CFD results.
Fantastic. Thanks, Oveis. And maybe I could ask, you've shown some beautiful results in terms of the CFD and the experimental models for acoustic deposition of medications. Have you had the opportunity to actually create some, to test it experimentally in human subjects?
That's a good question. Yes, we are doing clinical trials in Queen Elizabeth Hospital using phage. We are actually using our acoustic drug delivery technique to deliver phage to paranasal sinuses. The clinical trial is actually running, and we have had a few patients registered, not yet completed. We cannot conclude the final results, but it is good that we hear from our surgeons that all those 3 patients had very good drug delivery and had very good treatment for frontal and sphenoid sinuses despite their expectation.
Fantastic. Thanks, Oveis. We have another follow-up question from Jake. And he's asked that the resonance frequency was the same for all the sinuses in one nasal geometry. Does the resonance frequency change from person to person? So do we have to individualize the resonance frequency between patients?
Yeah, thank you for the follow-up question. That's a good question. Yes, definitely. Not only it changes for between patient to patient, but also it changes for one single patient during the time of the drug delivery from day 1 maybe to day 30, because if a patient get more infection and the size of the volume and the ostium, the size of the sinus and ostium changes, the resonance frequency changes. That's why we developed a method that measure the resonance frequency of a patient before doing the drug delivery, and then we use that number of resonance frequency to generate the acoustic wave. So it is really individualized.
Fantastic. Thanks, Oveis. Kiao, sorry, did you have a question?
Yeah. So firstly, thanks for the excellent presentation. This kind of translational research is really impactful and really bridges the science and theory to real-world applications. So that's really great. Question is, what's the effect of pressure and comfort on the patient when you introduce a resonance frequency into the nasal cavity, because that, with resonance, you can amplify the frequency. So how does that create any discomfort in the patient?
Yeah, that's a good question, which we really considered it when we wanted to do the clinical trial. We actually used the available standards for the highest level of amplitude of the acoustic wave that we can use. Of course, that is for hearing, and it is nose, and we believe that it can be higher than the hearing one, because of the eustachian tube is can make a barrier between the pressure, acoustic pressure from the nose to the air, to the actual air. But we actually use that one. We use the standard one, and yeah, if you increase the amplitude, it may be harmful for the patient, but for in terms of the resonance, to answer exactly your question, you want to say that if we use the resonance frequency, maybe we expect that the pressure go to infinity, but our results of the transfer function showed that the quality factor of the resonance frequency is about between 10 to 20. So this is somehow moderate. It is not high. If it is more than 50, so it is very high quality resonance frequency, and we can expect that there is no decay in the fluctuation, and it can go up to very high level. But because of the medium actually medium quality factor of the resonance frequency, it decays after a while. I mean, we apply the resonance frequency, it starts to go up, but it decays again because of the complexity of the nasal cavity. The energy is damped. Yeah, I want to say that, and it is good that we use this method for our patients, and patients didn't complain, and they said they didn't have any problem with it.
Fantastic. Thanks, Oveis. Now, we do have a couple of more questions from the audience. So firstly to Yidan. Hi, Yidan. How are you doing? Yidan asks, the micro CT images of particle deposition are very impressive. Agreed. Do you plot the images by yourself, or do you ask an external company to create those images?
Thanks, Yidan, for your question. Yidan is one of my collaborators, and recently published a paper together. And we did it ourselves. One of my students recently generated the plots using CTWorks software that is licensed by University of Adelaide. It is not hard, but it is also not easy. Maybe tedious, but yeah, it is tedious but easy to do so. We are happy to help you to do this if you want to collaborate.
Fantastic. Thanks, Oveis. And we have another question from Salah from Tabriz University. And he asks about the wall conditions of the 3D printed structures. How did you simulate the real physiological conditions of the body? Did you use a body-like material for 3D printing, or did you incorporate or coat with additives such as Tween 80?
No, we didn't use any human body material. We used a resin material. In terms of the resonance frequency, we tested different material, and we didn't see any change in resonance frequency. So we found that the material doesn't change the resonance frequency, but it changes. The resonance frequency can change just by the geometry. So that's why we didn't use other material. We started to use just cheap materials. About the human, about mimicking the real experiment, the clinical, the practice, we are actually working on coating the 3D printed model with bacteria and cell. One of my PhD students is going to work on that. And after that, this will be more realistic. But at the moment, we have not done this.
Good.
Thanks, Oveis. I might ask a question myself. So as you may be familiar, a paper came out some time ago about humming to treat sinusitis. And it's been suggested that humming can improve chronic rhinosinusitis and even increase nitric oxide production. Have you noticed similar benefits with applying sounds of the resonant frequency?
Yes, the humming is actually working exactly in the same way as we do. Humming is making the acoustic wave from the nasopharynx. We make the acoustic wave from the nostril, and the idea of acoustic drug delivery was actually triggered by humming when many years ago studies showed that humming can improve the air exchange, nitrogen oxide exchange between the nasal cavity and sinuses. Yeah, that can help, but we are looking for the best way. The best way is resonance frequency, I believe.
Fantastic. And in terms of practical terms, so in those clinical experiments that you're conducting, can I ask how long do you apply the sound for, and how is it applied? Is it something straightforward? Is it a few minutes, or does it mean you have to sit down while you're watching your Netflix every evening for an hour or so?
Yeah, that's a very good question. We actually developed a compact model of the nebulizer, including the nebulizer itself and the acoustic actuator. It is in maybe 20 centimeter in 10 centimeters. It is not very big. Like other nebulizers, you can sit on your sofa and see Netflix for 10 minutes and do the drug delivery. And at the moment, our patients are doing this every day, twice a day. 10 minutes for each side of the sinus, and 5 milliliter of the phage solution is delivered to each nostril.
Fantastic. Well, ladies and gentlemen, look, I know that there is a lot more discussion that we could engage in, but we have committed to keeping exactly to time. So we will conclude the webinar now. Please do remember to click on the link in the chat for feedback, and we will email the link out as well. And please do contact us if you would like to present a webinar yourself. So thanks again, Oveis, for a wonderful talk. Thanks to Kiao and Brenda for organizing such an accomplished speaker. And thank you all for attending. Thanks.
Thank you, guys.